Assalamu alaikum. Hello, everyone. Thank you so much for joining. My name is Khalid Jamiel. I'm a second year medical student. And
My
with
name is
me,
Areeba. Oh, I'm Areeba Shaikh. I'm a second year medical student as well.
and today, inshallah, we'll be giving you a renal physiology review. We'll try to cover the highest yield concepts in renal physiology in as many questions as we can. Hopefully, you'll find it beneficial, inshallah. If you have any questions regarding any concepts we explained in the PAL, you can always contact us. You have our contact information. So without further ado, let's get started.
Okay, so first question. A patient is infused with para-aminohypuric acid, which is PAH, to measure the renal blood flow. She has a urine flow rate of 1 milliliters per minute and a plasma PAH of 1 milligram per milliliters and a urine PAH of 600 milligrams per milliliter. What is her effective renal blood flow?
As you can either answer in the chat or if you feel like you want to talk, it's okay. You can unmute anytime.
So the answer would be C if you guys were to calculate the effective RBF. But I think since you guys didn't take it and we're only gonna look at the clearance, then yes, the answer would be A. So can you go next, Khalid? The explanation part. Yeah. So basically, PAH, if we look at the clearance of PAH, it is the filtered part and it's also actively secreted. So the entire renal plasma flow can be calculated when you know the clearance of PAH. And the formula for clearance would be clearance is equal to the urine excretion multiplied by the concentration of that substance in the urine and then divided by the concentration of that substance in plasma. So yeah, that would be A, and that's the formula.
And if you guys want to calculate effective RDF, you use the formula of clearance over 1 minus hematocrit. I'm not sure if you took this yet or not, but that's why the answer would be C in this question, because it's clearance over 1 minus 0.45, which would be 1090. So good job, Yasser, in the chat. I see you got it. I guess you took it on time. Okay, move on to the next question. Is this question clear, everyone? Okay. So a patient suffering from acute glomerulonephritis and his glomerular filtration rate is reduced from 120 to 80. If the rate of creatinine production remains normal, what change in plasma creatinine concentration will occur? Okay, we have an E in the chat. Another E. Okay. So you guys are correct. The answer is actually E. So what's happening? Basically, we can use the creatinine levels to tell us what's going on with GFR exactly. So what's GFR? It's the filtration rate, صح? And if we have a certain level of creatinine in the plasma and the GFR is normal, then from the level of creatinine in the plasma, we can know if GFR is normal or not. So usually, if we have zero creatinine in the plasma, we'll have a GFR of 125. That will indicate that the GFR is 125 or almost normal. Yeah. If the creatinine level starts to increase in the plasma, that means that GFR is decreasing. That means that we have a problem and we're not able to filter as much plasma as we usually do. okay, because creatinine is not getting filtered from the plasma. And so in this question, they're asking what change in plasma creatinine concentration will occur if GFR drops. And so if you follow this graph, if GFR drops from 120 to 80, the creatinine level will be more than it actually is. And since GFR and it dropped from 120 to 80 and now is 80, it's constant at 80, creatinine plasma level will be at an equilibrium, but above the normal level. So if we're at 120, for example, we'll be at 0 plasma creatinine. If then that drops to 80, we'll be at a higher normal, 2 or 3. That's also an equilibrium. It's going to be constant, but it's above normal. Okay, is that concept clear? So that's why A is wrong. They will reach a new equilibrium since GFR is now constant at 80. Is that clear to everyone? Okay, move on to the next question. So as GFR increases, plasma concentration of creatinine decreases because more is being excreted. Since production of creatinine stays constant, plasma concentration will eventually reach an equilibrium. This is in this case, but in the question, GFR is decreasing, so the opposite will happen. Okay.
Okay. So a 38-year-old woman is admitted to the hospital by her physician because of decreased urine output. Prior to admission, she was rehearsing for a dance performance and she had been taking Motrin for pain. Laboratory data reveals blood urine nitrogen as 49, serum sodium 135 millimole per liter, serum creatinine is 7.5, and urine sodium is 33 millimoles, and urine creatinine is 90 milligrams. Her fractional sodium excretion is approximately which of the following? Anyone? Should I just move on to the answer?
Okay, we have a D in the chat.
Okay. We have C.
Does anyone have any other answers? Okay, I think I can move on to the answer.
Okay. So the answer is D. You're right. And that would be because we are asking for fractional excretion. And fractional excretion is what? It's calculating the clearance of the substance they're asking for and dividing that by the clearance of aniline. And what does the clearance of aniline or creatinine give us? It's basically GFR. So fractional excretion is the clearance of any substance divided by the filtration, the glomerular filtration rate. Okay, so in this case, we have the values for sodium. We've got the serum sodium, we've got the urine sodium, and if you calculate that, you get the clearance of sodium, and then you divide that by GFR. Okay, and do not confuse fractional excretion for filtration fraction. They're two different things. So fractional excretion is trying to understand the clearance of a substance compared to the filtration. So if we have any substance that is being secreted more, so like we said, we have clearance of aniline or creatinine, right? And if the substance is being secreted from the peritubular capillaries into the tubules, it's being cleared more. So it's going to have a higher value than 1. And if it's being reabsorbed from the collecting tubules, etc., it's being reabsorbed. There's net reabsorption. That's what we use fractional excretion for. Filtration fraction is just to tell us the amount of fluid that is reaching the kidneys. So filtration fraction would be the glomerular filtration rate divided by the total renal plasma flow. And normally we have a filtration fraction of about 20%. Was that clear?
Okay, I think we can move on to the next question. Which of the following is filtered most readily by the glomerular capillaries? This is an extremely high yield concept. We actually got a question on the SAQ about this concept last year, so it's important to understand it. We have a D and an E. Any other answers? Okay, so basically the answer is actually C. So Noor, you're actually correct in the beginning. So let's explain this concept. So this is called Donen's distribution, okay? And now imagine this is the glomerular capillary, yeah? This is the glomerular capillary. And then inside the capillary, we'll have positive ions, we'll have negative ions, and we'll have proteins, obviously. We'll have proteins in the membrane, those are proteins, and we'll have proteins in the capillary itself, okay? Plasma proteins. And so the filtration rate depends on two things, okay? It depends on the size of the ion and obviously the charge of the ion, okay? So let's start with the size of the ion. If we have if we have big ions, which are from 18 to 42, okay, whatever this unit is, the positive ions will be filtered faster as they are pulled out by basement membrane proteins. So what does that mean? We have basement membrane proteins on the basement of the capillary, okay? And so if you have a big ion, if you have a big positive ion, these basement membrane proteins will pull the ion towards the Bowman space, and that will increase its filtration, okay? So the first thing we need to know, if the ion is big, the positive ions are filtered faster because they are pulled out by basement membrane proteins. So one of you might ask, why doesn't it apply to small ions as well? So small positive ions should be pulled out by the basement membranes as well. So that doesn't happen because they're simply too small for the basement membrane proteins to have an effect on. So these small cations, they can't be pulled out by these membrane proteins, basement membrane proteins, because they're too far away. And so they don't have an effect on those cations, but they have an effect on the big cations. Okay, so this is an explanation for the question here. Which of the following is filtered most readily? Polycationic dextran, which is basically cations, positive ions, with a molecular weight of 25. So 25 is between 18 and 42, so that's regarded as a big molecule or a big ion. Okay, and what about small ions? For small ions, the negative ions are filtered faster than the cations because they are pushed out by plasma proteins. So you see here we use the term pull, and here we use the term push, because see those plasma proteins flowing in the blood, they're all negative. And so those small negative ions are going to get repelled by these negative plasma proteins and pushed outside towards the Bowman space. Okay, so is the concept clear? So if the ion is between 18 and 42, positive ions are filtered faster. If it's less than 18 in size, the negative ions are filtered faster. It's very important to remember this concept. Is it clear to everyone? Does anyone have any questions? Okay, I think we can move on to the next question.
If the average hydrostatic pressure in the glomerular capillaries is 50, the hydrostatic pressure in Bowman's space is 12, the average colloid osmotic pressure in the glomerular capillaries is 30, and there's no proteins in the glomerular ultrafiltrate. What is the net pressure driving the glomerular filtration?
As the answer 8, عشان I think we sub like 50 minus 12, which is 38. Then we subtract 38 by 30.
Yeah, actually, it is A. So thank you for explaining as well. You would have the formula. You have the effective pressure is basically hydrostatic, the difference between hydrostatic pressures, and then the difference between the colloid osmotic pressures. But do you guys know why the colloid osmotic pressure in the Bowman space is 0? Okay, I'll just say it. So basically, when the blood flows in through the capillaries, we have high hydrostatic pressure, okay? And this hydrostatic pressure is the driving force at first for the blood to flow into the Bowman space and get filtered. Okay. Now, as the blood is flowing,
is it because glomerular ultrafiltrated is protein free?
yeah, exactly. So there is no protein that comes into the Bowman space. But what's the effect, you know? What happens is because there is no difference in the colloid osmotic pressures, the only thing that drives this filtration happening from your glomerular capillaries is the hydrostatic pressure. What I'm trying to say is, as the blood flows in, hydrostatic pressure is higher at first, okay? And then the blood keeps flowing through and the proteins get left behind. So what is happening is essentially as you're moving from, just a second. Yeah. So as you're moving from this area to this area and you reach like this spot, like this part of the arterioles, now you have way more proteins than you would have had in this side, okay? So your hydrostatic pressure keeps decreasing along the way and your colloid osmotic pressure keeps increasing along the way. And at some point, you're gonna have hydrostatic, the difference between the hydrostatics is equal to osmotic. Khalid, can you go to the next one? Yeah, so you see this graph. Basically, there's this is the hydrostatic pressure, and this is the hydrostatic pressure, and that is the driving force until the difference between them comes to a point where it's equal to the colloid osmotic pressure, and then filtration stops. Okay, and reabsorption cannot occur because this colloid osmotic pressure never became higher than the hydrostatic pressure. So whatever is filtered, it goes through into the Bowman space and it's never like taken back. Okay.
Using the following table and assuming that renal perfusion pressure remains constant, which of the following combined changes in afferent and efferent arterial resistance would result in an immediate increase in renal plasma flow and glomerular or filtration rate. We have an E, another E,
ايه
A,
لا ايه
E. Okay. Okay, good job, guys. The answer is actually E. But let's just explain it quickly. Oops. So this is the normal arrangement. This is the normal arrangement of the capillary. You'll have the afferent capillary over here and the efferent capillary over here. And in the middle, this is the glomerular capillary. Okay. So there are two factors affecting the GFR. Okay. One is renal plasma flow. So how much blood is flowing through the glomerular capillary. And two is the hydrostatic pressure of the glomerular capillaries, okay, as Areeba explained just a moment ago. So it depends on how much blood is flowing here and also this number over here. So these are resistances and this is the pressure inside the capillary, okay? So let me get 1 second. Sorry guys, just 1 second. So this is the normal distribution. You'll have the resistances of afferent and efferent, if they're equal, these will be the pressures, okay? So 100 here, and then due to this constriction, it will become even less over here. And then due to this constriction, it will become even less over here, okay? So how does the body control these things to change the glomerular capillary pressure? So if we constrict only the afferent arteriole, this one, the first one, okay, less blood is going to go inside. That's the first. And then also, because less blood is going inside, the pressure in the glomerular capillary will be lower than normal. Okay, so here it was 60 when the resistance was 1. And when we increase the resistance, which is basically vasoconstricting, we decrease the glomerular pressure over here. Okay, so this is a way a body controls the GFR is by constricting the afferent arteriole and keeping the efferent arteriole as it is. You will have a decrease in renal plasma flow and a decrease in pressure of the glomerular capillary, the hydrostatic pressure, and therefore you'll have a decrease in GFR as demonstrated here in the graph. The RPF is going lower and the PGC is going lower as well, so the GFR will also be lower. Okay, so you can think of those as an entrance and an exit. So if you close the entrance, less blood is going to go inside and therefore less hydrostatic pressure capillary. And it doesn't matter what you do to this, okay? Because if you close the entrance, less blood is going in. Now, this is where it gets a bit more confusing. What if we constrict the efferent arteriole but leave the afferent arteriole as it is, not changing it? You'll see that the glomerular capillary rate, the pressure increased. Why? It's because you're closing the exit. Okay, so if you close the exit, the blood will back up in the glomerular capillary, and therefore the hydrostatic pressure of the glomerular capillary will increase. Okay, and what did we say happens if the pressure increases over here? Does GFR increase or decrease? If we increase the pressure, the hydrostatic pressure in the glomerular capillary, what happens to GFR? Okay, it will increase, okay? Because, as we said, the two factors determining GFR are the renal plasma flow and the hydrostatic pressure of the glomerular capillary. Increase in renal plasma flow and hydrostatic glomerular capillary pressure will increase GFR. Okay, so here we increased the pressure because we closed the exit and the blood backed up over here. So the hydrostatic pressure here will increase and GFR will increase. However, what happens to renal plasma flow? If you're closing the exit, there will be less renal plasma flow. So now those are two opposing effects. So one effect is increasing GFR and the other effect is decreasing GFR. So what actually happens to GFR is when we have moderate constriction of the efferent arteriole, when the constriction isn't too much, the effect of the increase in the pressure is more than the effect of increase in RPF. It dominates over the effect of RPF, and therefore GFR will increase at the beginning. However, in severe constriction, when we reach a point where you can't, there's basically no renal plasma flow, alas, even if the hydrostatic pressure here increased, there's no more blood coming because there's no flow. Flow stopped, and therefore GFR will start decreasing. So basically, in moderate constriction, GFR will increase, okay, because the effect of the pressure, hydrostatic pressure, is dominant over the effect of the renal plasma flow. And in severe constriction, GFR will decrease because the effect of the decrease in renal plasma flow is dominant over the effect of glomerular capillary pressure. Now we go back to the question. It said, which of the following will result in immediate increase in renal plasma flow and GFR? And we just discussed that increasing the resistance over here will decrease GFR. So if we decrease the resistance, which is basically vasodilating, then we'll have the opposite effect, which is an decrease in GFR. Okay. I mean an increase in GFR. So as in this question, it says increase in renal plasma flow and GFR. So the answer will be, I hope it's clear to everyone. So I don't have any questions. Okay. I think we can move on to the next question.
Okay. A 26-year-old construction worker is brought to emergency department with a change in mental status after working a 10-hour shift on a hot summer day. The man had been sweating profusely during the day but did not drink fluids. He has a fever of 102 Fahrenheit, a heart rate of 140 beats per minute, and a blood pressure of 100/55 in the supine position. Upon examination, he has no perspiration, appears to have dry mucous membranes, and is poorly oriented to a present place and time. Assuming that his kidneys were normal, which set of hormone levels describe his condition compared with the normal? Okay, D. Anybody else? Okay. Okay. So it's all going to be high because of the renin-angiotensin system. There are two things to know about this diagram, especially there's GFR increase and there is a decrease. So when the GFR increases, we're gonna have a lot of fluid that's coming in through the tubular fluid, right? And if you have a lot of fluid coming in here, if you have a lot of fluid coming in, you're gonna have a lot of sodium delivery to this place. And then the sodium is gonna go into the cell and then it's gonna go through the sodium ATP pump, okay? Now, when the ATP pump is used more and more, we have a lot of ATP present in that area. We also have a lot of metabolites of the ATP. So we have ADP or ADO, all these stuff. And these things can go and they can bind to the mesangial cells and they will stimulate the release of calcium, okay? So this is high blood pressure, right? and high blood pressure, and then eventually you have release of calcium. It'll cause vasoconstriction. And another thing that calcium does is it decreases the renin release. Okay, so in the case of the complete opposite, if you have less GFR, you're gonna have less sodium delivery. You're gonna have this pump is not working like it was, and you're gonna have less of these. So you're not gonna stimulate the mesangial cells, and you're not gonna release calcium. So if you're not releasing calcium, you end up increasing the renin release. Okay, uh, renin releases angiotensin, and we're gonna see the effects of angiotensin as well. Can you go next? Okay, so renin-angiotensin system, it works with because of two reasons. If you have lower renal perfusion or if you have hyponatremia, in both cases you have low delivery of sodium. Okay, so in our case, in our patient, he was dehydrated and he didn't have fluids. So what do you think happened? It was lower renal perfusion, right? You didn't have enough you didn't have enough blood flowing through, basically. So that case, you're going to have low sodium delivery. And if you have hyponatremia, so maybe they're not dehydrated, but the amount of sodium is less, you're still going to stimulate the release of renin. And renin will actually go stimulate angiotensin 1, which is then converted to angiotensin 2. But the end result is that it releases angiotensin 2. Angiotensin 2 has a lot of effects. First thing it does is it releases ADH. ADH, it increases the H2O absorption in the kidney. So if you absorb more water, you're gonna increase the blood volume and you're gonna increase the blood pressure. And angiotensin 2 can also stimulate vasoconstriction. So you're gonna have total peripheral resistance, and if you have resistance, you're gonna eventually increase blood pressure. And angiotensin 2 also stimulates the release of aldosterone. Aldosterone, it increases the sodium absorption, but what happens when you reabsorb sodium is that you also reabsorb water with it. So you're gonna end up increasing the volume again, and again you're gonna increase the blood pressure. And lastly, angiotensin will increase the thirst receptor, like the thirst system, basically. So you're gonna want to drink more water, and if you drink more water, you're gonna increase volume, and all of these just help increasing the blood pressure. Okay, that's why when you see our patient, everything was high. The renin was high, angiotensin, aldosterone, and ADH. All of these were high. Okay.
Okay, anyone have any questions regarding the last question? Okay, so soluble transport is regulated in the thick ascending loop of ending predominantly by which of the following mechanisms? We have E. We have another E. Okay, so the answer is actually D. And let's see why. Yeah. So now this is the thick ascending loop of ending. Okay, and the answer says potassium moves from cell into the tubule fluid via potassium channels. Okay, so this is the tubule fluid, and you see this is the tubular side, and this is the basolateral side. Okay, and you can see there's a potassium channel over here taking potassium into the tubular fluid. Okay, and that's exactly what the answer is saying. It moves from the cell into the tubular fluid. Now, everyone that said E, Na plus is secreted in the tubule fluid via NaCl minus symphylated. Na plus is never secreted into the fluid. Okay, see, it always enters the blood through NaCl minus symphylated or what other channel, whatever other channel there is, but it's never secreted in the tubule. Okay, so this is why this answer will be wrong. It's not secreted in the tubular fluid. It's always absorbed. And also, this is not an NaCl minus importer. This is an Na2Cl minus K plus importer. There's another NaCl minus importer in the early distal tubule. It's not this one. They're not the same. Okay, so be very precise with your answers, because this is how they're gonna trick you in the exam. They're gonna make tricks like this. Na plus Cl minus importer, and you think it's this one. This one is not called NaCl minus importer. It's called Na2Cl minus K plus importer. Okay, so I made a summary about the potassium transport mechanisms and the different parts of the tubule. So Na plus 2LCl minus K plus importer for absorption. This is only found in the thick ascending loop of Henle. This is also a trick you can use when studying this lecture. Always memorize the special things, because that's what they're going to ask you about, the special things, okay? So Na plus 2Cl minus K plus importer is only found in the thick ascending loop of Henle, and this is one mechanism of K plus absorption. Another one is H plus K plus ATPase antiporter, which is in the late distal tubule. And this is a very special channel because it's the channel used to control acidity and the amount of potassium in the blood, mainly by aldosterone. And then you have paracellular absorption of K plus. This is one side of it, the thick ascending loop, and also in the proximal convoluted tubule. Now for secretion, you have K plus channels in the thick ascending loop and loop of Henle and the late distal tubule. So this channel, and you have exactly like this in the late distal tubule. And then other potassium channels that aren't like mainly for absorption or secretion. One of them is the Na plus K plus antiporter on the basolateral membrane. So remember, this is the luminal membrane and this is the basolateral membrane. Don't let them trick you with this, okay? Basolateral membrane is from the cell into the blood, while luminal membrane is from tubular fluid into the cell, okay? So you have an Na plus K plus antiporter almost everywhere in the basolateral membrane. This is a method of absorbing sodium. After sodium enters, you want it to go into the blood, so you need this channel. It's present mostly everywhere. Then we have potassium Cl minus importer on the basolateral membrane and only the thick ascending loop. This is only present in the thick ascending loop of Henle, not anywhere else, because this is one of the few places where we absorb potassium. So we need to absorb it all the way. So we need the channel on the basolateral membrane as well. And then finally, we have the leaky channels on the basolateral membrane, and this is also present almost everywhere. And it's always present where this is present. Whenever this is present, the Na plus K plus antiporter on the basolateral membrane will have a leak channel along with it, because when potassium enters, it needs to leave. We can't have potassium like accumulate here or go over there. So you need a leaky channel to make potassium leave and recycle this this channel. Okay. So clear, everyone? Okay. Next question.
Okay. So this image shows tubular fluid over the plasma ratio for several different substances that are freely filtered along the length of the proximal tubule. Which of the following best describes the proximal tubule reabsorption of the substance represented by line 3? Okay, D. Okay, so yeah, it is D. It is reabsorbed at a rate that is slower than water reabsorption. Okay, so to understand it, let's look at the graph first. So we have the ratio on the y-axis, right? What does one mean? One means that the tubular fluid concentration of that substance and the plasma concentration is the same. So if it stays as 1 throughout the proximal tubule, it is not being reabsorbed more than the water. Basically, in the case of creatinine, we see that the ratio is higher, right? And that means that the concentration is more in the tubular fluid. So we're absorbing more water, okay, and we're leaving it behind. That's why the concentration is increasing, right? So it's getting reabsorbed slower than the water, and that's why it's staying behind, and that's why the concentration keeps increasing. Okay, so if the value becomes greater than 1, this means that the concentration has become higher, which indicates that the substance is being reabsorbed less than the water reabsorption. Now if we go towards the lower parts, or like these parts of the axis, this part which is lower than 1, these are all substances that end up getting reabsorbed more than the water. Okay, so in the case of glucose, you see how it reaches this point, so it's almost all reabsorbed more than the plasma. Okay, so when a substance is reabsorbed more than the water in the tube, in the proximal tubule, then the ratio will decrease less than 1. So in our question, our line, the line number 3, it was going above 1, remember? So that's why we said, yeah. So if this is 1 and it's can you go back? Thank you. If this is 1 and we come at this point, we see that this ratio, it corresponds to a value higher than 1. So this line indicates that this substance is being filtered less than the water, so it's staying behind, and that's why the concentration in the tubule increases. Okay, is that clear? I hope that was clear.
Okay, we can move on to the next question. I think it's yours as well.
Yeah, okay. So the image below represents the renal tubular principal cell, and it shows membrane transporters of sodium and potassium, labeled A, B, and C. And just to clarify, this orange one is a sodium potassium ATP pump. Okay, so it's the ATPase pump. After acting on the nuclear, sorry, where was I? Yeah, as well as the binding of ADH to its receptor. So this one is ADH binding, and after acting on the nuclear, why can't I read? I'm so sorry. After acting on the nuclear mineralocorticoid receptor, the effectors of aldosterone action in the principal cells will enhance which of the following? So basically, when you have aldosterone, which one of these is it going to affect? E, okay. Any other answers? Okay, so I'll move on. The answer is E. It will be A, B, and C only. Basically, what happens is, can you go next, Khalid? Thank you. So this is the picture from your slides. Basically, this aldosterone will come, it'll bind to its receptors, and what it does is it'll go to the mRNA. Okay, it'll go to the mRNA and it will activate protein synthesis, and these proteins are basically the sodium channels, which was A in the question. Another thing it's going to do is it will also enhance synthesis of the sodium potassium pump. So you're going to have sodium channels more, and you're going to have more sodium potassium pumps. So that's A and C. And the it doesn't do anything to the potassium channels. It's not synthesizing the potassium channels. However, because we're going to have more action of the sodium channels and the sodium potassium pump, you're going to enhance the actions of the potassium channel as well. And as you can see, it has nothing to do with the ADH receptor, okay? That's why it was A, B, and C. So when aldosterone binds, it'll go activate the mRNA, enhance protein synthesis. And another thing it is going to do is it's going to activate the mitochondria. So what's the mitochondria going to do? It's going to produce ATP so that the ATP can work this pump more and more, okay? So aldosterone, we know that aldosterone works to do what? It works to increase the sodium reabsorption, right? That's why when it comes and it increases the sodium channels on the side, you're going to have more sodium reabsorption. And then this sodium is not going to accumulate inside the cell. It's going to have to move out. And that's why you're going to need more of these sodium potassium pumps. And to work the sodium potassium pumps, you're going to need ATP. And since this one exchanges sodium for potassium, the potassium is going to need to move out. And for that, this potassium channel starts to work more, okay? Another thing that happens is indirectly, aldosterone ends up stimulating this channel as well. It's a K plus H plus antiporter. And basically all the potassium that you're going to be removing into the lumen, it's going to go here and it's going to exchange, and H plus is going to be secreted out instead, okay? So what you can remember is aldosterone, it stimulates these four channels: sodium channel, sodium potassium, potassium channels, and potassium and hydrogen channels. And this one is going to end up increasing the hydrogen secretion into the tubule. And the potassium channels are also going to increase the potassium secretion into the tubules. And what about the sodium? The sodium is going to be absorbed more, okay? So that's the effects of aldosterone. This is just everything that I explained, but I wrote it down. So when aldosterone binds to the receptor, it activates mRNA, produces more sodium channels, produces more sodium potassium pumps, and activates the mitochondria, so you have more ATP. And since the sodium reabsorption was enhanced, right, one more point. So since sodium is being reabsorbed more and more, what's going to happen to the charges? You're reabsorbing a lot of, what's the word? Positive ions, right? So essentially, when you're absorbing all of these positive ions, you're going to also reabsorb calcium. But calcium is not going to go through the channels. It's just going to go from between the cells. So it's reabsorbed paracellularly. Okay? And yeah, that's it. Is that clear?
Okay. A 12-year-old boy is diagnosed with polyglandular autoimmune disease that initially causes failure of the zona glomerulosa in his adrenal glands. Which of the following conditions would be present in this patient based on his reduced plasma level of aldosterone? So basically, this patient has a deficiency in aldosterone. So what do you think the answer will be? Any guesses? Do you have an E in the chat? So the answer is actually E. So basically, what happens, as Areeba explained, during aldosterone, if there's aldosterone, it will increase the absorption of sodium and increase the secretion of potassium and hydrogen. Okay, so this is the net effect of aldosterone. It will increase the absorption of sodium and it will increase the secretion of potassium and hydrogen. Okay, so if we have hyperaldosteronism, which is extra aldosterone, which is not the case in the question. Okay, but if we have hyperaldosteronism, you'll have high in sodium retention. You'll have hypokalemia because more potassium is being excreted, and then you'll have alkalosis as well because high amounts of hydrogen ion is being excreted out of the body as well. Okay, so this is in the case you have hyperaldosteronism. Now we'll just apply the opposite effect on hypoaldosteronism, which is low aldosterone. We'll have hyperkalemia. Okay, so here we had hypokalemia, here we have hyperkalemia. And I like to do something when it comes to renal. Always have reset rules in your mind in case you get confused in the exam. High aldosterone is hypokalemia and alkalosis, alto. So this is where you start. If you get confused in the exam, don't try to build your way through from the beginning. Just reset yourself with this. And high aldosterone is hypokalemia and alkalosis. So if high aldosterone is hypokalemia, that means aldosterone increase the secretion of potassium and hydrogen ions. Okay, and then because you reset yourself with this, you can then answer that. Okay, and low aldosterone equals hyperkalemia and acidosis. So just memorize one of them, and the other one will be the opposite. So either memorize only this, or either memorize only this, and from there you can figure everything. You can figure out the mechanism of action of aldosterone. You can figure out what aldosterone causes, either hyper or hypokalemia, and so on. Okay, and you can also link it with hydrogen secretion or absorption due through alkalosis or acidosis. So this is a follow-up question on the same concept. A patient presents with metabolic acidosis. Metabolic alkalosis could directly lead to which of the following? Oops. Yeah, I guess you guys got the concept now. So as we said, okay, so this guy has alkalosis. And so we said alkalosis is linked with hypokalemia and high aldosterone. So this is a very beautiful summary made by Dr. Shams of what could cause hypo or hyperkalemia. So in hypokalemia, we have something called thyrotoxicosis, which is increase of thyroid hormone, but you don't need to know this. We have diarrhea or vomiting. And then the main things you need to know is mineralocorticoid increase, which is aldosterone, renin, and all the other things. And also the high distal Na plus delivery, which as Areeba explained, will increase renin, angiotensin, and everything else. Okay, and then for hyperkalemia, we'll have opposites plus lactic and ketoacidosis, which is obvious because acidosis. This is also a type of acidosis, so it will do the same thing as normal acidosis, which is it will reduce the secretion of potassium, and it will lead to hyperkalemia. Okay, so always link hypokalemia with alkalosis and hyperkalemia with acidosis, and then for aldosterone, you can link them by these. And high aldosterone is hypokalemia and alkalosis. Low aldosterone is hyperkalemia and acidosis. Please remember those very well. Okay, it's important. It's very important. Clear, everyone? Go to the next question.
Right. So in the ascending limb of Henle, salt is pumped out of the tubule and into the interstitium to maintain an osmotic difference of 200. What happens with the movement of new fluid from the proximal tubule entering the descending loop? Okay, you're saying A. Okay. The answer is actually C. So I think it's the wording that kind of confused, because osmotic equality is not set to another value. So the difference is still going to remain as 200, okay? So basically, we have this little hypothetical model, and this part, the left part is the proximal tubule, okay? This is where the proximal tubule starts. And then we have a building of the gradient. So this is the start. The fluid comes in, everything is 300 milliosmoles. And then we're gonna have a salt movement first, okay? And this salt movement is salt without the water. So it's just salt moving in from here to this tissue. And you build a difference of 200 between the two, okay? Now, what happens is you have this 400 here, and you have, I'll just say it weird. It's 400 here, 200 here, and it's 300 here, okay? This side cannot move water. That's basically why only salt moves in from the tube into the tissue. But this tissue and this part, they can have water movement between them. So as soon as you have this osmotic difference between them, what's going to happen is that water is going to move in from the proximal tubule into the tissues, and they're going to balance out their osmolalities until they're equal. Okay, so now they reach this equality, like this equilibrium, and then more fluid comes into the loop. So we have this new 300 moving into the proximal tubule, and what it does is it pushes everything that was already there along the tubule, right? So this 400 that was here will now come and reach this part, and now again, the same thing that happened over here is gonna happen over here. So you're gonna have salt movement without the movement of water, and this movement is going to make sure that the difference is going to remain as 200 between them. So this 200 and 300 are going to become 350 and 150 to make sure the difference is 200. And the similar thing happens with these two as well. The difference remains 200. So the question was asking what happens when you have more fluid coming in. And that was the scenario where you have the new 300 coming in, and all of the values get pushed away. And what happens is that the salt is pumped again, and you reestablish the difference of 200. Was that clear?
Okay, so we can move on to the next question. Changes in the afferent. Oh, this is yours as well. Sorry.
I think it's mine. So changes in afferent input from the high pressure baroreceptors and low pressure volume receptors alter the rate of ADH release. What is the threshold to affect ADH release? Okay, so you're saying A. Any other answers?
We have the D as well.
Okay, so the correct answer is D. What did we say ADH does? ADH is gonna act when your blood pressure decreases, right? So A is not gonna be correct because the blood volume is increasing. So you're not gonna increase ADH if your blood volume is already increasing, because ADH will help you to increase the blood volume. Okay. So can you go to the next one? Yeah, the graphs. Yeah, thank you. So we're gonna have two things that stimulate the release of ADH. You have osmolality and you also have blood volume. So this question was asking about blood volume. So you need to have at least 10% decrease in the blood volume. And once you reach this point, that's when you have an increase in ADH release. So this is just the normal point, and this is all the increase in the blood pressure, but you're not gonna have ADH release This is the point where you reach 10% decrease, minus 10. So you're going to have this linear graph that's basically releasing ADH. Now, when it comes to osmolality, when you increase osmolality and you reach a point of 280, when the osmolality has increased to 280, that is the threshold for the release of ADH. Okay, so these are the 2 points basically that you need to reach, and then your body starts to release ADH. Okay, so ADH is not like aldosterone, right? Aldosterone, what did aldosterone do? It would absorb sodium and then effectively reabsorb the water. So here, when we look at the effects of ADH, the excretion of electrolytes is gonna remain unchanged because it does not affect the ions, it only affects the water. And this red graph is basically the osmolality. So if we look at the x-axis, it's gradually increasing the ADH. And if we look at the osmolality, it is increasing, right? So as ADH increases, the osmolality will increase. And as the ADH increases, it's going to affect the urine excretion rate or the urine volume. Okay. So ADH is going to affect water. That's why it's only going to affect the osmolality and the urine volume. It's not going to affect anything happening to the electrolytes. Okay.
Everything clear, everyone? Okay. Let's get to question. Which part of the renal tubule would have the lowest tubular fluid osmolarity in a patient who has complete lack of antidiuretic hormone due to central diabetes insipidus? Okay, answer is saying A. Any other answers? Okay, so the answer is A, it's correct. So basically what happens when we have ADH, water is able to, this is the medullary collecting, okay? And so water is able to move to equilibrate with the tissue fluid over here, okay? So you'll see that this layer is 300, so the water inside the medullary collecting duct will be 300 as well, 500, 500, and so on, okay? And this is in case you have ADH in which water is reabsorbed. We want to reabsorb water, and therefore the urine will have very high osmolarity, okay? However, if you don't have ADH, like in the case in this question, the water cannot leave, okay? So here there will be no reabsorption of water, and this is the first place in which the osmolarity inside the tubular fluid will not equal the osmolarity outside here because water is not able to absorb. Okay, so and then here it keeps on decreasing until it becomes 65, which is very low osmolarity, which tells you that there's very high water inside the medullary collecting duct. Now the question was asking, in the absence of ADH, where will the osmolarity be the lowest? And you can see that it's the lowest in the medullary collecting. Now, here it's 100, okay, and there's no reabsorption of water. Here as well, it's 100, but there's no reabsorption of water. That's why. Why does it keep on decreasing here? Although, the same effect of ADH over here and over here is the same. But here it keeps on decreasing and decreasing because salt is also leaving. Okay, so with leaving salt being reabsorbed, and also water not being reabsorbed inside, or not being reabsorbed and kept inside, the osmolarity will keep getting lower and lower until we're at lowest in the medullary collecting duct. Okay, is that clear, everyone? Okay. Next.
Okay, so which of the following sets of physiological changes would be expected to occur in response to increase in atrial natriuretic peptide? Okay. Okay, so the answer is D. It would decrease, and then increase. Okay, so there are many types of atrial natriuretic peptides. We have the atrial one, you have one that's BNP, which is brain natriuretic peptides, but effectively they all have the same effect, okay? So from the name, they're natriuretic peptides. So natri means sodium, it's referring to sodium, and uretic peptides, so they put the sodium into the urine and like let it go, basically. So first we're going to look at the arterioles. What effects do natriuretic peptides have on the arterioles? They have for the afferent arteriole, they're going to dilate it, and for the efferent arteriole, they're going to constrict it. What happens is, we saw this earlier, if you dilate it, you're going to have more blood flowing in, and then the efferent arteriole, if you're constricting it, you're going to have essentially a lot of blood that's there in the filtration part, right? In the glomerular capillaries. So you have an increase in the hydrostatic pressure. And what's going to happen if you have an increased hydrostatic pressure? You're going to increase the GFR. Because remember, the GFR is most dependent on the differences in the hydrostatic pressure, right? So you're increasing hydrostatic pressure, and then you increase the GFR as well. Another effect that it has is it decreases the aldosterone action, and it does that in two ways. So it can directly go and it can directly reduce the synthesis of aldosterone from the zona glomerulosa. And it can indirectly go and reduce renin, because we saw the renin-angiotensin system, and renin will indirectly activate aldosterone release. So if you're going to decrease renin, you decrease the entire system working, and then you're effectively decreasing the aldosterone. Okay, so two ways to decrease aldosterone. Another thing is that these natriuretic peptides will decrease the sodium absorption. Okay, it does that by affecting the medullary collecting ducts. You don't really need to know the mechanism of it, but it also contributes to low sodium reabsorption. So basically what happens is you decrease the aldosterone, and then you decrease this as well. You affect the medullary collecting duct, and you have all these things contributing to low sodium reabsorption. If you are reabsorbing less sodium, you are effectively reabsorbing less water. So you can tell that these natriuretic peptides work when the blood pressure is higher, okay? Because you're trying to reduce the water volume, right? You reduce the Na reabsorption, you reduce water reabsorption, and effectively you're reducing the blood volume. Lastly, these natriuretic peptides will inhibit the water reabsorption, and that too can have two effects. Basically, either they're going to directly inhibit the ADH action, or they're going to inhibit the release. So they're going to go and interfere with the release, and then you're not going to have ADH, or they will just directly antagonize the ADH, and it cannot act and reabsorb water. Okay. This is just the same thing that I said, but it's showing that the heart is, okay, by the way, guys, the heart is the place where you have ANP and BNP release, the natriuretic peptides, because that's where they have receptors for blood pressure. So they will go and affect the kidney, and they will increase GFR, they will decrease renin, they will decrease angiotensin, aldosterone, and basically decrease the blood volume. Okay. So we saw that these are the effects that happen when the blood pressure increases, but there was also this part about like the detailed part of angiotensin action to decrease the blood volume for some reason. But we'll just look at that as well. So angiotensin, it can affect the afferent and efferent, and what it does is it will actually constrict both of them. However, it will constrict the efferent way more, okay? So what happens is you're going to reduce the renal blood flow because you're constricting the afferent arteriole, but you are increasing the constriction of the efferent even more, Okay, so effectively you have less renal blood flow, so less blood is coming in. But since your efferent is even more constricted, you're letting the blood stay there more. There's more pressure, so there's more filtration happening. Okay, so you're gonna have more filtration happening, and what's gonna happen because of the filtration? Can I change the color? Yeah. So when you're filtering more from here, you're leaving the blood there for a really long time. The water is going to keep moving. And then by the time the blood moves to the peritubular capillaries, you're going to have more protein concentration. So you're going to have more colloid pressure, and you're going to have less hydrostatic pressure because the water was moving in here because you had it stay there for a longer time. Okay. So you increase the proximal tubule sodium reabsorption because you let it stay there for a long time, basically. Another thing angiotensin does is it will decrease the medullary blood flow. So medullary blood flow is the blood flow that supplies the kidney itself. Basically, it will affect this part, the vasa recta. What it does is, can you just go next, Khalid? Like the white boxes. Yeah. So what it does is when the blood flows through here, it's gonna decrease the washout. It's not gonna absorb the salts from the place, okay? So you're gonna have more solute in the medullary tissues and they're not being washed out. And then in fact, you just have low sodium and H2O excretion, okay? Because these things are just gonna hold them and they're not gonna let it just like leave into the tubules and go out.
Okay, guys, we're almost done. We reached the last two lectures, acid and bases, and then finally the last lecture. So just bear with us. Urine samples of 5 individuals are collected for acid-base analysis. The total concentration of phosphate buffer in each sample is 30 moles per liter, and pK of phosphate buffer is 6.8. The pH for each sample is as follows. We can see the samples. Which urine sample has the lowest buffering capacity of phosphate buffer? Yasser is saying D. No one have it. Okay, D as well. Excellent. So it is D, and it's exactly as Yasser said. It's because there's the highest pH pK difference. Okay, so this is the buffer curve. Okay, and this portion over here shows the buffer capacity, which is where the buffer will work the best and where the buffer could actually show a difference. Okay, and this depends on the pH of the sample and the pKa of the buffer. Okay, so it depends on the pKa and the pH of the sample. So that means that different buffers have different activities in different samples. So for example, the phosphate buffer has a pK of 6.8. Okay, so it will work best in a pK of 6.8, and it will not work in a pH of 8.6. Okay, so it depends on the pK and the pH, and the greater the difference between pH and pK, the less effective the buffer is, and the less activity it will show. Is that clear, everyone? Okay. This is a follow-up question. Which of the following is the best intracellular buffer? So basically, which buffer works best inside cells? We have a B,
C.
C. So the answer is actually C. This is pure memorization. It has a bit of understanding, but you need to memorize it as well. So basically, we have different buffers in the body in different parts of the body. Because as we said, we need the buffer to match the pH of the solution, okay, in order for it to work best. So inside the cell, we have phosphate, which is the best buffer inside the cell. Why? Because the pH inside the cell is 6.8. And that's exactly the pK of inside this of phosphate. I mean. So that's why phosphate is the best intracellular buffer, and also it's a good buffer because it's in very high concentrations. Okay, except in the red blood cells. Inside the red blood cells, the buffer is actually hemoglobin. So the best buffer in red blood cells is hemoglobin. However, in all cells in general, the best buffer is phosphate. So you need to memorize this. Another buffer in the body is bicarbonate CO2 buffer. Now, this is the best buffer in the blood. So one might ask, if the pH of the blood is 7.4 and the pK of the buffer is 6.1, there's a very huge difference. Why is it effective? Okay, it's effective because one, it's present in extremely high concentrations in the blood. Okay, so that's one reason for the buffer working well. It's very high, it's in very high concentrations in the blood. So that compensates for the difference in pK, pH. Okay, another reason is because it's an open buffer. So what do I mean by open buffer? Since carbon dioxide is being released through breathing, and as soon as it's produced in the blood, it gets released by breathing, by ventilation, and therefore it's kind of helping the buffer as well. It's removing the acid, and therefore it's not allowing the blood to become acidic, helping the buffer in controlling the blood pH. If this was a closed buffer and the carbon dioxide is not getting removed by the body and ventilation is not helping this buffer, then it will be a bad buffer and you won't be able to buffer the blood properly. However, Kaman, if you think about it, so it gets disrupted. Like, it doesn't get disrupted, it gets helped by CO2 release. If CO2 was kept in the body, you'll get acidosis. So if ventilation wasn't helping this buffer, the blood will be acidic. But because ventilation is helping this buffer and it's getting rid of carbon dioxide as soon as it's produced, the buffer works well and there's no acidosis. And if the buffer was very good, if the pK of the buffer was actually 7.4, let's say, however, and it was an open buffer, then there will be overcompensation. There will be alkalosis because the buffer is working very well. And above that, you're removing carbon dioxide. So now there is an imbalance. Okay. So basically, ventilation helps balance this buffer. Okay. Because it gets rid of carbon dioxide as soon as it's produced, helping the buffer. Although the buffer, there's a huge pK/pH difference, it still works well because one, it's in high concentrations in the blood, and second, it's an open buffer. So I hope this concept is clear. And for the last buffer you need to know about is amino acids. We have 3 amino acids that can work as buffer. One is the histidine, and specifically the imidazole ring, which is a group in histidine. Then we have the amino group in all amino acids. And finally, sulfhydryl group of cysteine. So cysteine, histidine, and amino acids in general, they can all work as buffers. And these are the ranges. Now, this is not very important, but I just put it here for completion's sake. Just can we have a look on it? Cysteine works best in the range of 5.5 to 7.5, while cysteine and amino group work best in the 6.5 to 8.5 range. So I hope this is clear.
Okay.
Yes.
Yeah, I just couldn't. Buffer basis is the sum of total concentrations of bicarbonate and buffering proteins. Even though we get the bicarbonate from a carbon dioxide reaction, what is the reason that buffer bases are not dependent on PCO2? Okay, B. Any other answers? Any guesses? Okay, so it is B. It does involve reciprocal relationship between bicarb and B minus. So we're just going to look at the parameters for acid-base analysis. We have 2 types of them. We have respiratory influence indicators, and we have the non-respiratory influence indicators. So we have one that tells us, okay, it's because of the respiratory influence, and the other is like metabolic, body, whatever. So respiratory influence, it's really small. It's pH, PCO2, and actual bicarbonate. Now, pH is just the concentration of H plus. We know that. We know PCO2. Actual bicarbonate, it's not a good parameter because if you just take the concentration of bicarbonate from a person at any given time, there could be a lot of changes. There could be a lot of respiratory or metabolic changes. So this one's not a good parameter. Moving on to the non-respiratory influences, we have standard bicarbonate. So standard bicarbonate is when you take bicarbonate of the person in a well-oxygenated blood sample and at a certain temperature. So if it's well oxygenated and it's with normal PCO2, you're not gonna have any influence of respiratory factors. So any changes in the bicarbonate, if it's well oxygenated and it has normal PCO2 and everything, that would indicate that there's something wrong in the non-respiratory factors, okay? Then we have buffer bases. So buffer bases is the total concentration of bases, which is the bicarbonate and any other buffering bases. And an increase in bicarbonate would result in a decrease in the other buffer bases. So we have this reaction over here. And basically what happens is this carbon dioxide reacts with water, and that's how you get bicarbonate and you get H plus. Now the H plus is buffered with another protein. So if at all there is an increase in bicarbonate, you're having an increase in H plus, and essentially it's gonna go and it's gonna bind to the B minus. So you're gonna end up decreasing the concentrations of B minus, right? So they have a reciprocal relationship, and that's why it's not dependent on the pressure of carbon dioxide. That's also why it's a non-respiratory influence indicator, okay? Lastly, we have buffer excess, and this is what we use the most in clinics. And it is the difference between the actual amount of buffer bases in the patient, in the person's body, minus the normal amount. So you would have a certain value minus the normal is usually 48. And we use that as the most common indicator. Was that clear? Okay. So the next question is, a 50-year-old man with history of type 2 diabetes was admitted to the emergency department with history of polyuria. On examination, he had rapid and deep breathing. He had a pH of 7.3. PCO2 was 22. Bicarbonate concentration was 15. And the base excess is -7. And these are also the normal ranges given. So after compensation, which point on the Davenport diagram would represent the above scenario? Okay. Okay, so the answer would be A. It would be point A in the diagram. First, we're gonna look at how we determine what's the scenario so that we can pinpoint it into the Davenport diagram. Okay, so we have three things to look at. First thing we look at is the pH of the patient. Okay, so we're gonna have pH here is 7.3, and 7.3 is lower. So what does that mean? That means the patient is going through acidosis. The next thing we're gonna look at is the patient's PCO2. Now PCO2 is low, it's 22, whereas normally it's 40. So when the PCO2 is low, does it cause alkalosis or acidosis? Anyone? Okay, I'll just tell you. It causes alkalosis, okay? Because you're having low CO2, so yes, alkalosis. So low CO2, so less reaction and therefore less H plus. So if PCO2 is indicating alkalosis and the pH is less, then we're gonna say that the respiratory factor is not the reason for this acidosis. And then we're gonna move on. We see bicarbonate is 15, and we see that the base excess is -7. Now, whenever base excess is a negative value, that indicates acidosis, okay? Because we have the formula, which is the normal amount of bases, the actual amount of bases in the body minus the normal amount. So if the actual amount is less than the normal amount, we're going to have negative. That would represent acidosis because these bases are being used up to buffer, right? That's why the actual amount would be less than normal, and that's why we would have a negative base excess. So we determined that it is metabolic acidosis. And what does this represent? This represents respiratory compensation. Okay, so first thing that happened is metabolic acidosis. That means this point here is going to move along the isobar of PCO2 40. Okay, so if it's acidosis, it's going to move down, so it will move along this line. But we said that there was compensation, which was lowering of PCO2, so this point will move down, and therefore you will have point A. So this is just the rule. First, you look at the pH, determine if it's acidosis or alkalosis. Then you look at the PCO2 if it if it justifies the pH value. Like we saw that it doesn't justify because our PCO2 was indicating alkalosis. So if it's justifying, then the cause is respiratory. And then we look at the buffer excess and we see the metabolic state of the patient. Okay. Okay. So just to this is just to summarize the whole thing. If there is any metabolic cause, this point is going to move along the isobar, okay? Because the PCO2 is not changing. The changes are happening because of anything else in the body. And if the changes are respiratory, then it's going to shift along the red line, the buffer line, basically. Okay, so this is just a way to space yourself, like, okay, if the point is here, it's probably this. So if the point is, for example, here, we would say that it's partially compensated respiratory acidosis. And why? Because this point would have to move along the buffer line, and that would indicate a respiratory cause. And then if it's somewhere here, then that means some compensation would have happened. Okay? Okay, so next question. Since we looked at the parameters and how to figure it out, this is just a question to test that again. A 21-year-old woman presents feeling acutely lightheaded and shortness of breath. These are the acid-base parameters. We have pH 7.52, PCO2 is 30, HCO3 is 17, and the base excess is -6. So what is the status of this patient? Okay. Okay, yeah. You guys are right. It's partially compensated respiratory alkalosis. Why? We look at the pH. pH is high, so it's alkalosis. Then we look at the PCO2, it's low. So it justifies the pH. So it's a respiratory cause, so respiratory alkalosis. And when we look at the base excess, we see that it suggests acidosis. So it's basically the compensation.
Okay. A 60-year-old man has a cardiac arrest and cardiopulmonary resuscitation is performed. Epinephrine is administered. Measurements of blood gases and plasma electrolytes were obtained immediately after resuscitation and revealed the following values. Arterial pH was 7.3, arterial PCO2 was 28, lactic acid was 3, plasma HCO3 was 14, plasma Cl- was 100, and plasma sodium was 130. Which of the following acid-base disturbances is present? Do we have a D? With another D? So the answer is actually A. Yeah. So let's explain this concept. Now, what's lactic acid? It's an acid, obviously, صح? And we can see that the lactic acid is above the normal. Okay, so that's lactic acidosis. This is a condition we call lactic acidosis. Okay, and this explains the pH, which is lower than normal. Okay, so it's a metabolic acidosis that's due to lactic acid. Now, our arterial PCO2 is 28. That suggests alkalosis or acidosis. Alkalosis. So basically we're trying to compensate respiratory. So that's why respiratory acidosis would be wrong. Okay. And it's definitely a metabolic acidosis. Now we introduced a new concept called the anion gap. So what exactly is the anion gap? So normally in the blood, there is no such thing as an ion gap. The total amount of positive ion should equal the total amount of negative ions. Okay. So the plasma, there's always an equal amount of positive ions with negative ions. However, we made a new value called the anion gap, which helps us determine the cause of the acidosis, whether it was a true acidosis or whether it was due to the GI or something wrong with the kidney. Okay, so this is only for metabolic acidosis. As soon as we see the term anion gap, we can throw respiratory acidosis outside and alkalosis and everything else. This is only for metabolic acidosis. Okay, so how did we bring this anion gap? You see these group of anions, we basically just cancel them. We don't calculate them anymore. And so if we, this is the equation of the anion gap. If we subtract the total amount of cations minus the total amount of anions without those, we'll have a gap, which is basically the amount of those anions. Okay. So the normal gap would be 10 to 14. Now, in certain conditions, we'll have a normal anion gap metabolic acidosis, and in certain conditions, we'll have a high anion gap metabolic acidosis, and that helps us determine the cause. Okay, so when we have high anion gap metabolic acidosis, this will be due to low HCO3 without chloride loss. So we don't have chloride loss, but we have lower HCO3 due to the acidosis, obviously. And this is always due to metabolic defects, always. So lactic acidosis, ketoacidosis in diabetes patients, and so on. Okay. So this will have a high anion gap because if HCO3 decreases, but Cl stays the same, then we'll have a high anion gap because this value decreased, okay? And this value will increase the anion gap. And this is the case in our question. The patient has lactic acidosis and therefore he will present with a high anion gap metabolic acidosis. Now, we have normal anion gap metabolic acidosis, and this is always due to GI or renal problems, okay? So due to low HCO3, but there's an increase in Cl minus. Okay, so the Cl minus compensates for the loss of HCO3, and therefore will have a normal anion gap. Now you don't know exactly how there's an increase in Cl minus in these conditions, okay? But you just have to know that in normal anion gap metabolic acidosis, the main thing is that it's due to GI and renal problems mainly, and you'll have a normal anion gap because Cl minus compensates for HCO. Okay, and examples of these would be diarrhea and renal tubular increase. Okay, clear everyone? So let's calculate it over here. You'll have 140 minus, minus Cl minus plus HCO3, which is 140 minus 140, which is greater than 10 to 14. Okay, so if they don't give you potassium in the question, since potassium outside the cell is very low anyways, and sometimes they don't give you potassium in the equation, and so you can just ignore it and use sodium, because sodium is the main cation outside the cells. Potassium, magnesium, and calcium all together, they're not high outside the cell, and so you can neglect them. So if they give you something without potassium, just use sodium. Okay,
Okay, so a website for high altitude hikers explains that after a rapid ascent, one begins to hyperventilate, but then the kidney compensates for it. What is the renal response to this condition? So basically, what is the kidney? Yeah. So decreased rate of the tubular H plus secretion. Basically, we'll look at this diagram first, and you have all these tissues that you have CO2 coming in, right? And CO2 will react with water, and then what do you get? You get bicarbonate and you get H plus. And H plus is then secreted into the kidney by HB, which is buffering transport, but that's not important right now. So in the kidneys, you excrete H plus and also bicarbonate. So if you're hyperventilating, what's going to happen? You're going to end up decreasing the CO2 amount, right? If you decrease the CO2 amount, however, you keep like excreting these H pluses, what's going to happen? Eventually, you're going to have very little amount of H plus in your body, in your blood. And that's going to affect your pH, and it's going to end up causing alkalosis. So if there's a hiker going on an ascent and they're hyperventilating, they have a lot of CO2 being released, they're gonna decrease the H plus excretion from the body so that you can maintain the pH. Okay. Another diagram for it is you don't have to know everything, like everything from this diagram. I just want you to see that lungs give off CO2. That's how you get rid of CO2 from the body. And kidneys give off H plus secretion. And kidneys also excrete the bicarbonate, okay? So CO2 is gotten rid of from the body by the lungs by expiration, and H plus and bicarbonate is excreted from the kidneys. So if there is anything happening in this place, in this equation, you can just figure out like which balance is gonna shift.
So now we reach the last lecture. These questions, Dr. Abdul Ahad likes to repeat them every single year, so we know them very well, and he's probably going to repeat them for you too. So which one of the following is the primary muscle of micturition that contains mechanoreceptor to aid the expulsion of urine from the bladder? Can you have an E in the chat? Yeah, so it's basically, it's an easy question. But you need to know it because it gets repeated every year. The primary muscle that contains a mechanoreceptor in the bladder is the detrusor muscle. Okay. For the next question, the image depicts the results of a cystometrogram that showed that the patient has a normal control of micturition. Which patient or which phase of the cystogram would have been most altered in the case of overreactive bladder? This is also just pure recall. Yes, exactly. Answer is B. Okay, so this phase over here, which is called the filling phase, is the most affected phase in the case of an overreactive bladder. Basically, it gets shorter, okay? Because if your bladder reacts more to urine, this phase will get shorter, and therefore you urinate more, okay? And this is the case in old people and people with diabetes. Not true, but that's in the case of old people for sure. He said pay attention to this part here. This is the question he's gonna get. So this was it. Does anyone have any question? Thank you all for attending, and hopefully
Thank you,
benefited.
Khalid. شكرا
And
خالد، شكرا
of course,
ريبة حتى.
Thank you.
good luck in your preparation. Thank you guys.
Also, don't forget to scan the code and fill the form. Thank you.
Good luck in POD حتى.
Thank you.
Thank you.